in summary, opioids, diabetes drugs, and anticoagulants are the big three of adverse drug events. Quality Insights is working with partners to address this issue. And in particular, next slide, please, we are taking some of the best practices that we learned today, things that have worked in the inpatient setting, things that have worked in the outpatient arena, and applying them largely in the outpatient setting, I believe, is where the support and resources and tools are greatly needed. So some of the disciplines that you see on the screen are those that we're looking to get involved with us. And next slide, please. And please join us in doing effort, just as our first speaker, Dr. Kleinschmidt, said, things that you may already be doing, but perhaps we can help you with tools, resources, and education to enhance what you're doing, or perhaps you wanted to do some kind of education, but you didn't have quite right the tool, or you didn't know exactly how to go about it. Join with us, and you can obtain many toolkits and resources for these big three that we think will be really useful to you. And in addition to that, you get access to our My Quality Insights, which is our online learning platform. So work with us to implement simple, common sense best practices targeted towards these big three things that you can incorporate into your regular workflow. And all we ask in return is that you're willing to share back with us, yes, I'm using this anticoagulant chart, or yes, I'm using these teach-back cards, and this is about how many patients a month are impacted by that. And that's all we ask in return, actually, is for you to share with us the impact of what you're doing just at that level. And there's a couple of links to our website and what the login for the My Quality Insights looks like. Many people on the line may already have a login. If you do not, join us and we'll get you one. Next slide, please. Just a quick example of a couple of the tools and resources available. So here's an anticoagulant table that we put together that summarizes all the oral anticoagulants, including warfarin. And don't take a screenshot or print this out and use it just yet. We're actually in the middle of updating it. There's a couple of new indications for one of the NOACs that we're getting on there. So stay tuned for the updated version. And then another thing that a lot of our partners are using is these clinical teach-back cards, and they cover all the big three drugs and antihypertensives and a few other cardiac meds and groups as well. And they're a really great tool not only to use when educating patients, but also in educating staff throughout a health system, let's say, or throughout a pharmacy chain, let's say, so that messaging can be consistent as people travel throughout the continuum of care. So those kinds of things you want to keep in mind. Join with us. Next slide. And here are contacts for each one of our states that we have on the line today. So please reach out to your state contact if you're interested in getting involved. And now that my sales pitch is over, I would like to open the floor for, we'll take some questions. We cannot open the phone lines because it would be too noisy, but we strongly encourage people to chat in their question either to everyone, or if you feel more comfortable chatting in directly to the host, please feel free to do that. And we love to hear what's on your mind. I have a couple of questions myself. So while we're waiting for some of the questions to come in, the question that I had was for Dr. Kleinschmidt on the opioid presentation. You mentioned a little bit about opioid alternatives, such as a combination of ibuprofen and Tylenol together. Are there other opioid alternatives that you can speak to with regards to either the acute pain setting or chronic pain setting? And also, how are you working on the outpatient side, or how are you working with the community on the outpatient side to kind of continue the work that you start as people travel through your facility and then go back out into the community?
Sure. I think that's a great question. So in-house, for some of the pain, a lot of it's in the operative setting. So for acute pain, there are a few IV options that you could use. The number one being Toradol, which is actually an NSAID or ketorolac. You can use it for a set number of days, and that's actually pretty helpful. It works very well. You can also use Tramadol. That's an oral medication that can be utilized. These are chemically similar to opioids. However, they do not have the same effect on the mu receptor that causes the addictive quality. Another one that we can use is Lyrica. There's been a lot of advertising for that, or pregabalin out. And those are kind of the three main ones that we've been utilizing quite a bit instead of the opioids. Regarding patients in the outpatient setting, I really think the hospital is an opportunity to set people up correctly for success on the outside. So when they leave here, we review their discharge, and if a prescription doesn't seem appropriate or there's too much of it, we can make that rec and say, hey, instead of this strength of oxycodone, we could try maybe this strength of Vicodin, which would be less potent. In the ED, we don't give big prescriptions quantity-wise for patients on discharge. If they come to the ED and they have pain issues, they're typically more than likely admitted, and we kind of figure out what the underlying cause is before we send them back into the community. Hopefully that kind of covers it a little bit for you.
Yeah, that was really helpful. And at this point, Lori, I'd like you to comment in with other questions that are coming in from the participants.
Yeah, we do have a couple questions. The first one is, has dose doctor ever worked with patients with intellectual disabilities, and do they send orders in writing?
Sorry, I had to unmute my thing. I'm not really sure I understand the question about sending orders in writing. Generally, if we're working with a physician, I basically ask them what the physician group or a clinic can enroll their own patients and manage them on their own. If not, I contact the PCP, find out what the prescription is supposed to be, and import the prescription. In terms of intellectual disabilities, the individual themselves would not be using it, but they're a caregiver, right? So a mother for their child might have the app on her phone for the diabetic child, or the same thing for an elderly adult. A child might have the app on their phone and they just communicate with their parent. So in a sense, yes, but the prescriptions are either made by me or communicated to their primary care provider. We work with PCPs and endocrinologists, not instead of them.
Okay, thank you. And another question that was just entered is for the clinical pharmacist, or rather her colleague who is on the line, which would be Mark Greenberg. Do they bill for clinical pharmacist review of patient medications and recommendations?
I'm sorry, can you repeat that? Can you hear me, by the way?
Yes, I can. The question asks, do you bill for clinical pharmacist review of patient medications and recommendations?
Well, we do not bill the client at all, if that's what you're asking. And there's no, the VNA does pay for our service here, but there's no additional cost for our adherence packaging for the patient. Hope that answers the question.
Okay, thank you. Our next question is for Mike. This intervention identifies patients when they come into the hospital and works with them while inpatient. How is this approach to pain management carried forward once the patient is discharged?
Sure. I think a patient, when they are in-house, it gives us an opportunity to kind of sit down and figure out why they're here. And once we kind of determine why they're here, we can really tee them up for success on the outside. So a lot of times patients will come in and they are not effectively managed with their pain. And so when they're in-house, we can go ahead and augment and change their orders to better reflect best practice. And on discharge, there should always be a focus on new, changed, and discontinued medications. And if the patient clearly understands the changes that we made in-house, we can set them up for success. Those are for pre-existing orders. For patients who are discharged, we can make sure that the orders and the prescriptions that are given to them are available and effectively managed for them on the outside, so the dose isn't too much and the duration isn't too long. So let's say you get a tooth pulled, I keep using that analogy, you're not going to need a month's worth typically of pain medication, and that's a recommendation we could make to the doctor. Say, hey, instead of 21 days worth, how about 3? And that's something that we've done, and I think anybody can do that on the outside, not just in a hospital, but in any setting, really kind of look at the appropriateness of the order and go from there.
Okay, great, thank you. Next question is for Dr. Williams. What happens when a patient is admitted to the hospital? Is dose doctor continued, and how is that operationalized?
Usually I notice that someone's not entering their blood sugars into their phone, and I say, hey, what's up? And they say, oh, I'm in the hospital. That's fine, no big deal. Tell me when you're out. And what happens usually is because the prescription is actually on the phone, the patient can show the admitting doctor what is there. We do not facilitate inpatient management of diabetes. Usually that's got some protocol in the hospital. So the patient goes in with a prescription, they leave with the prescription, and I communicate personally with the patient, ask them, hey, what did they send you out on? And usually it's whatever they went in on or something ridiculous, and we just go back to what was working beforehand. So I know it doesn't sound very good politically, but the inpatient setting is sort of like a pause, hold, they do whatever they do, and we come out, the patient and I sort of fix it, personalized to them on the back end.
Okay, and for Mike, is the hospital working on any other initiatives that support community-based best practices, such as through the emergency department or affiliated physician practices, et cetera?
Absolutely. Something I'd like to do to grow this hospital, and I think is an opportunity across the board in this country, are ambulatory care settings. I truly believe that pharmacists in and of themselves, with a collaborative practice agreement with physicians, stand to be in an opportunity to really affect care outside of the walls of the hospital. What's the best way to treat somebody in a hospital? Is to prevent them from ever coming in the first place. So with that in mind, I'd like to see in the next 12 to 18 months, particularly here, ambulatory clinics set up, run by pharmacists, focused on, as Dr. Williams had mentioned, diabetes management, pain management, anticoag management. There's a lot of opportunities out there in the community that pharmacists can assist with. It's just a matter of getting those programs up and running, getting that initial funding and the buy-in, and I have no doubt that they will take care of themselves, both financially and with the services provided for the community.
This is Nicole. I have a quick question, and then we're going to wrap up. Actually, with regard to Dr. Williams, with regard to the Dose Doctor app, assuming that all the information that's transmitted, HIPAA compliance is built into that, patient identifiable information is properly encrypted, et cetera?
Correct. Right. We are high-tech and HIPAA compliant. You can't actually have a certification, but we use an online service called Aptable, whose only purpose is to maintain HIPAA compliance. So the information is kept very limited. We don't collect all HPI, name, date of birth, phone number, and glucose and insulin, and it's transmitted in a de-identified way. It'd be really hard to get access into our system. There's no interface, no API. So all the things that make apps and health systems vulnerable, we don't have.
Okay, very good. Well, it's just about the top of the hour, so we're going to have to wrap it up. If anyone's question was not answered, please reach out to your state contact and we'll get it answered, or to Lori Fink, our host, or myself. And thank you, everyone, for tuning in today. And just one quick message. Our next Care Coordination and Medication Safety webinar will be Thursday, December 15th. We're doing it again a week earlier than usual due to the Christmas holiday, 2 p.m. Eastern, 1 p.m. Central. The topic is motivational interviewing as applies to patient-centered care. Please be sure to tune in on that day. And also check your emails. Our next quarterly email newsletter will be going out shortly with more information about how to prevent the big 3 of adverse drug events. Thank you all for our wonderful presenters today. And please do the post-evaluation survey. And Lori, did you have any final words before we sign off?
No, I was going to just remind everybody about the evaluation. It is only a couple questions and should only take a minute or two to complete it. That feedback really does help us to know if we hit the mark on what you're hoping to learn from participating in this initiative. So please do complete that survey. And thanks again for joining us today. I hope you have a great rest of the day. And this now concludes the session.